country on earth can have people who need to work for their daily bread. No country is immune. Each and every country has to really make sure that this is taken into account.
Thank you very much. Next question, Associated Press, Jamie.
Hi, can you hear me?
Yes.
Great. Good afternoon. My question has to do with the situation in some European countries. We've seen some signs that countries like Italy and Spain may be sensing that they are reaching the peak, and that I believe the UK also mentioned some experts there, or one expert there mentioned that they may be nearing a peak. I'm just wondering if you have any estimates. I know that, Mike, you said on Friday that there's no way to sort of see the end of this, but what about peaking? Do you see any signs of peaking within Europe? Thanks.
If you just look at the extent of transmission in those three countries you mentioned, we wouldn't compare them to Korea or to Japan or to Singapore in terms of their situation. They have much more extensive problems. And then if you compare them to what happened in China, and specifically in Wuhan, which was the most intense epidemic, we did see, rather than basing this on modeling, let's base it on experience, right? We saw what happened in Wuhan after the lockdown, and not only did they do that physical distancing and put people in their homes, but they continued to look for cases. That's the essential distancing measures, and the stay-at-home orders is the number of significant contacts per case has dropped from the 20s to 15, to 12, to 10, to 8, to 4, which means less people have been exposed to that case than would have been 2 weeks ago, which shows people are distancing. For whatever reason, they're distancing. So there are less people at risk from any individual case. If you get those cases out of the community quickly, they'll expose even less people. And that's how you get ahead of an epidemic. So do we hope that Italy and Spain are nearly there on that? Yes. But the way you stabilize and then move to zero, and I think everyone's talked about the curve up, and everyone talks about the stabilization. The question is, how do you go down? And going down isn't just about a lockdown and let go. To get down from the numbers, not just stabilize, requires a redoubling of public health efforts to push down. It won't go down by itself. It will be pushed down. And that's what we need countries to focus on. What is the strategy now to put in place the public health measures that will push down the virus after those measures may be released? And then how do we take care of people better in a clinical environment to save more lives? So yes, potentially stabilizing, and it is our fervent hope that that is the case. But we have to now push the virus down, and that will not happen by itself.
And if I could just add to that, what I was going to say, which Mike has just said, is we need to focus on the now. We need to focus on what must be done now to get us out of this. And there is this, I understand completely the desire to want to know when we will reach the peak and when we will start seeing that decline, but that will not happen on its own. These physical distancing measures, these stay-at-home measures have bought us a little bit of time, a little window of time. And that short window has to be used appropriately so that we get systems in place to look for this virus aggressively through testing, through isolation, through finding contacts, through quarantining those contacts, through caring for further patients, because we will still see patients, and many patients are still going to require need to support other countries that are going to go through this. So the focusing on what we do now is absolutely critical to make sure we use that time wisely, we use that time effectively, so that we do, once we do reach that peak, that we continue to push and suppress that virus down as quickly as possible, but still be ready to find additional cases should they show up. What we've seen in a number of countries in Asia, and that where they've brought this virus down, they've brought transmission down, they're now seeing repeat introductions from outside of their countries. They have not let their guard down. They are still aggressively looking for those cases as they come in and suppressing it so that it doesn't start again. So we need to focus on the now. We need to use our time wisely, and that is to aggressively find this virus and care for it.
Nippon TV. Okay. That's okay. So let's go to Jim from Westwood One. Jim, can you hear us?
Yes, thank you very much. Very good afternoon to you. I would like to clarify a little bit on the chloroquine issue in the U.S., and it should be important to point out that the FDA hasn't approved it for wide prescription by doctors, but only in a hospital setting, and the doctors there can only get it from the national stockpile. But my question is, what exactly was observed with chloroquine or hydroxychloroquine that could lead to the possibility of it being used to treat COVID-19 in a hospital setting? And what do you mean exactly by randomized testing as opposed to non-randomized testing? If you could answer those, I'd appreciate that. Thank you.
Maria will supplement. I mean, there was somewhat people will describe as in vitro evidence, evidence in the lab that the drug was active against the virus, but any number of things are active against viruses. Chlorine is active against viruses, but other things are active against viruses. The question is whether they're safe and effective to put in a human body, and whether they will be absorbed and processed in a way that the virus can be attacked and not the body. From the perspective of chloroquine, there were also some small observational studies, one in France, that followed a small number of patients where there was no randomization of those patients and looked at their outcomes. Patients were admitted at different stages of illness, and the outcomes that were really focused on was the length of illness. And the observation that was made was that people, length of illness or length of hospitalization or length of significant symptoms was reduced. No one here is talking about cure. No one here is talking about taking a magic pill and all of a sudden you recover from COVID. Everyone's looking for therapies that will shorten the disease illness, will prevent people going from moderate to severe, and will prevent those that are critical dying. And drugs act in different ways. Some drugs may actually prevent the virus replicating early in the disease and therefore shorten the length of the illness and reduce the progression to severe disease. Once the disease is very well established and in a later stage of the disease, a lot of the damage that's being caused by the virus has not necessarily been caused by the virus itself, but all of the secondary effects, the inflammation, the drug or the organ failure and other things that happen. So a lot of antiviral therapies are focused on getting a person with the disease treated at an earlier stage of disease. And if you look at a lot of the anti-flu medications like Tamiflu and others, their main benefit that has been found for those, again, has been shortening the course of illness. With regards to randomized control trials, the importance of having a control group is to have a comparison. And then be able to stratify your patients, because if I have a drug and I treat a very severe patient who's of an older age with the drug and that person dies, does it mean that that drug didn't work? And if I treat a really healthy young person who's got a moderate disease and they recover, does that mean the drug worked? And I don't think any of us need to be rocket scientists to work out that there are many factors that predict recovery or predict death. And what we have to separate and we have to distill out is what is the effect of the drug itself, not the age of the patient, not the condition of the patient, and so many other factors that can affect survival. We've all been through infectious diseases ourselves and we recover. Is that because we get out of one side of the bed or the other? No, we wouldn't assume that that was affecting the outcome of the illness. There are many natural things affecting illness outcome, including the hard work of doctors and nurses in supporting the patient and preventing organ failure and ventilating the patient. So the difficult thing at this moment is distilling out the specific effect of a drug in a complex illness. And that's what we're trying to do with the randomized controlled trials. And that's why we need so many patients in those trials across many countries, many age groups, genders, many phases of the disease, and many levels of severity. And then we can break out what is the actual effect of the drug on the outcome of the disease.
Only to add that there are a number of clinical trials that are ongoing. Mike?
What we're trying to do with the randomized controlled trials, and that's why we need so many patients in those trials across many countries, many age groups, genders, many phases of the disease, and many levels of severity. And then we can break out what is the actual effect of the drug on the outcome of the disease.
Only to add that there are a number of clinical trials that are ongoing. Mike has described the French study that I'm aware of as well. But there are a number of clinical trials that are ongoing that look at chloroquine, that look at a number of other therapeutics. And on the one hand, it's incredible to see this acceleration of research and development and this focus on the evaluation of therapeutics for COVID-19 patients, which is building upon a history of other respiratory pathogens that have plagued us. But the challenge is that many of these clinical trials are small in size, which makes it very difficult to draw any conclusions, which is why it is very important that we have these larger trials, these multi-site trials, the Solidarity trial that WHO is running, to be able to have enough cases to be able to get an answer to which drugs work, safely.
Thank you very much. We have time for one or two more questions, so I'll try with Bloomberg and Naomi. Naomi, can you hear us?
Hi, yes, I can. Thanks for taking my question. Wanted to ask, we've seen some different approaches to quarantine in China and in European countries, with group quarantine used to good effect in China. Do you think that home quarantine will be as effective anywhere for people who are positive, or would central quarantine be needed in order to have the same success that China had?
Hi. Yeah, so we get our terms right and we can explain ourselves properly. We tend to use the word isolation for someone who is a case, confirmed. We tend to use the word quarantine for someone who's at risk of being a case, usually a contact. So on that basis, we advise that all suspect cases are tested and all suspect cases are isolated in an appropriate medical facility. I think nobody disagrees with that, where the capacity exists. When we come to contacts, it very much depends on the context and the intensity of the epidemic at any given moment. In low incidence areas where there are sporadic cases or clusters, we advise that all contacts should be quarantined. Ideally, that quarantine should occur in a place other than the home. And for this reason, one, because if that person gets sick, they may already have infected their family. But that's not always possible. So at least quarantining contacts at home with good health advice about not transmitting disease if they become sick, and with regular monitoring of that individual, is an option for countries. It is difficult to do that in the middle of intense transmission, where you might have hundreds of thousands of contacts because you're having thousands of cases a day. It is difficult to deal with that. So home quarantine of contacts is acceptable with appropriate information, education, and more importantly, a very rapid system of getting those people out of their homes if they become sick. I listened to the president of Singapore this morning, and he had a conference call with the Director General, and the clarity of that in Singapore, that ability not only to isolate cases, but to rapidly detect illness in the contacts and remove those contacts should they become sick, was a central part of that. And as he said, that wasn't, they're using apps now to do that, they're testing apps, but they didn't do it with apps in Singapore. They did that with community workers, with public health workers, visiting the houses, checking on people, checking their health status every day and saying, how are you? Have you got a fever? Have you got a cough? And if a contact has developed a cough or a fever, they were taken immediately for testing. So yes, we need the information technology tools. They help. They are not the solution. There is, right now, we don't have an alternative to what we would have considered in the old days boot leather epidemiology. Public health practitioners, doctors, nurses, community workers working with communities to detect cases at community level. And the most likely person to become a case is someone who's been a significant contact of another case. And at the moment, in most parts of the world, due to lockdown, most of the transmission that's actually happening in many countries now is happening in the household, at family level. In some senses, transmission has been taken off the streets and pushed back into family units. Now we need to go and look in families to find those people who may be sick and remove them and isolate them in a safe and dignified manner. So that's what I was saying previously about the transition from movement restrictions and shutdowns and stay-at-home orders can only be made if we have in place the means to be able to detect suspect cases, isolate suspect confirmed cases, track contacts and follow up on the contact health at all times, and then isolate any of those people who become sick themselves.
Thank you very much. As we try to have a variety of different outlets being able to ask questions, we don't have quite often sports outlets, so I will call on Diane from soccer.com. Diane, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, please go ahead.
Hello?
Yes, please go ahead with your question. Diane, let's try one more time. Can you hear us? We were hearing you very, very well.
Yes, I'm sorry. I'm having my phone. Hello, can you hear me now?
Yes, please go ahead.
There is such a discrepancy of information regarding the validity of masks, and I know that you have addressed this, and there's a great deal of fear regarding medical professionals having access to it. But is there any type of qualitative research that can confirm that the masks, wearing a mask prevents the spread for normal transmission in going to the supermarket, in day-to-day activity?
I can start, and perhaps Mike or the DG would like to supplement. So this is an area of very active research. There's a lot of use of masks globally for different diseases, for influenza, for other coronaviruses, for this particular outbreak. But there isn't a lot of quantitative analysis of this. And what we know works, we know that people who are sick and they stay home, that works because that prevents them from spreading the disease to someone else. We know that washing your hands works because we know that or using an alcohol-based rub, because that will remove the virus from your hands. We know that physical distancing works because that removes the opportunity to spread that virus from one person to another. We are working with a large group of people across the globe and our IPC specialist networks to look at the use of masks in various settings. First and foremost in healthcare facilities, so that we could better understand how PPE was used by healthcare professionals as they treated patients, in which types of departments they were working in, under which types of conditions, the severity of those patients. That's the real focus of a lot of the research right now to ensure that we protect our healthcare workers. So we are working with a number of groups across the globe. As those results.
Be very careful to ensure you can keep up that level of testing. So it's an issue of balancing the use of your test against their value. And again, it's like any detector system. Testing is a detector system. You can turn up and down the sensitivity of that system as long as the batteries last. So that's the issue. How long will your tests, the available tests, if you know I've got X number of tests available to me over the next month, then how am I going to use those tests over the next month? So countries have been limited by the number of available tests, and that's important. Countries have also had to ration tests according to the intensity of the disease in different parts of the country. So therefore, the return rate or the percentage of confirmed tests will vary. But we would certainly like to see countries testing at the level of 10 negative tests to 1 positive as a general benchmark of a system that's doing enough testing to pick up all cases. Now, it can be more or it can be less, depending on the circumstance. It's not an objective, but you really do want to see a lot more. You would be very, you know you're missing a lot of cases if 80 or 90% of the people you test are positive. You are probably missing a lot of cases.
And if I could just add to that, to say that a lot of the challenges that countries are facing, a lot of the argument that comes back is just, well, we just don't have enough. And so just to say what WHO is doing and what countries are doing is they're trying to find tailored diagnostic solutions to their needs, to meet their needs of their countries and the outbreaks that are happening in their countries. And that includes a variety of things that we are doing and countries are doing. The first is to increase the capacity of the labs, so the number of labs that can actually conduct that testing. So whether these are national labs or academic labs or private labs, but increasing that number of labs, increasing the number of people that can actually run those tests, finding individuals that can run those tests. The second is increasing the production and availability of tests. There's a huge number of tests that are on the market right now, thanks to the rapid sharing of sequences, full genome sequencing of this virus in early January. And then the third, we are working very hard to have a tailored support to country based on their need, based on what they have in their individual countries, whether these are benchtop or manual PCR kits, or whether these are automated PCRs, or whether these are high throughput machines. There's not one single solution to increase your ability to test, but it is important that you continue to do so so that you know where the virus is.
I think it has been said. I just wanted to add, testing is very, very important. I cannot even emphasize it more. There was a meeting of ministers. This was last Thursday, I think, and we had, some of the practices from 4 countries, actually, what they have done. The common factor in all 4 countries was the testing. Testing is important to understand the status of an individual, but testing is also important to see what the situation looks like. For instance, from the presentations of the 4 ministers, we saw that when they test, they go back and check those positives, how they got the infection. Some of them could be from a church gathering or a religious event, or others could be in a bar or a restaurant, or others could be in a social gathering for some purpose. And then the testing is not about that individual. It becomes about the event that happened and how to really address such events. So the testing doesn't tell you just a story about one person. It's a story about what happened when that person actually acquired the infection. And that helps you to trigger your public health interventions. Take Korea. When it started, the community transmission, it was actually in a religious event, really, and address thousands of people events ended up being. So the testing doesn't tell you just a story about one person, one gathering. It's a story about what happened when that person event was actually acquired the infection. Lead was, and that helps you to trigger your public health. So one was the religious event, and the other one was the hospital, where they saw when it started. The community transmission, it was actually and how they mobilized their public health intervention to address not only that, but also other clusters. So without knowing, without testing, it's like moving blindfolded. So testing can help us not only to know the status of individual persons, but to know also what's behind it, and take public health measures. And that's why we're saying testing is very important. And from testing, you can do the contact tracing. From there, you can also isolation. But we fully understand when there is community transmission, the health system could be overwhelmed. Even the public health interventions could be very, very, very heavy. But there are ways to tailor our public health interventions, even in such situations. And the isolation may not necessarily be in a hospital or health facility. It could be in a community facility. Many countries have very innovative ways of isolating because their health system was overwhelmed and they had to actually look for community facilities. And then the last resort is when they couldn't do that and when they have a number of cases and when there is community transmission, then some of them resorted into isolation in their home. And separating their bedrooms and separating the utensils they use. But then let's be practical. Okay, you can have your own bedroom or you can have your own this or that to isolate yourself and to take all the precautions you need. But if it's in a developing country, for instance, where I grew up, if it's a one room where there is a big family, like 5 or 7 people in one room, how do you implement that? And then that's why we say we don't have a one-size-fits-all solution. And the solution should really be tailored to the situation of each and every country. So how do you implement isolation in a situation where a single family, a big family, is living in one room or 2 rooms and isolation is not possible at all? So that's why we say one-size-fits-all solution cannot happen. And each and every country knows its situation in terms of COVID situation. It knows its own social and other factors, and it knows what solutions it has at hand to have a successful public health solutions. So that's what we're saying. And of course, necessity is the mother of invention. And we expect a solution in every situation from the communities themselves and from the government and the country itself, because each and every situation is very unique. And each and every community knows the problems, knows the root cause of the problem, and knows the solution. And it doesn't need any prescription from anyone. The general guidance we give can help you to really get solutions in your own way. The most important thing is how can we trigger the human spirit in unison to address the problem that we are facing in each and every community. Thank you.
Thank you very much, Dr. Tedros. With this, we will conclude today's press conference. We apologize to all those who have not been able to ask the question, but there will be other opportunities. We will have an audio file sent to you in the next hour, and hopefully transcript will be posted tomorrow. Have a nice day and evening wherever you are.
Thank you, Tariq, and thank you for joining us, and see you in our next presser. All the best.